Welcome, everyone. I'm Greg Stanley. I'm here with Dr. Ron Peterson. Ron is a periodontist, a coach at Whitehall Management, and an academic of some renown. Uh, if he doesn't mind, I'm going to have him comment on that before we're done. But so many perio questions come up among our consulting clients, and here's a chance for Ron to share some of his insights about perio and hygiene with everyone at once. Do you mind doing that, Dr. Peterson?
Not at all, my pleasure.
Okay. One of the questions we get is, hey, Whitehall says we're doing too much perio. Does that mean we're not supposed to do perio? Isn't that illegal? In other words, there's all kind of questions about trying to fit patients' true needs in with their financial willingness. What have you learned about that?
Well, there's some basics to always remember, and your question was well framed. As doctors, we have legal and ethical obligations to our patients, and I can tell you from my board experience that they're real. You better do it. So the things that we have to do, there are 5 things that we must do at an examination. We have to do a thorough examination. We have to record our findings. We have to discuss our findings with the patient. We have to make treatment recommendations, and we have to discuss the possible consequences or outcomes of the choices that we've presented. So those are legal obligations. Now, people can interpret that as just piling everything onto people. And that's great, but if you do, you're going to overwhelm them, unless it's your brother or your next door neighbor that you go hunting with all the time. A patient that doesn't know you is easy to overwhelm. And as anybody who's attended Whitehall seminars in the past knows, overwhelmed patients don't buy less, they buy nothing. They go away because they're overwhelmed. So the question then that comes to us immediately is, if we're marketing, as most offices do now, and we're bringing in patients who don't know us, really have no connection with us at all, but they're going to check us out because of something that appealed to them from our marketing, these people are easy to overwhelm. You can overwhelm them by presenting too much, presenting things they weren't expecting, or getting off on a tangent somewhere along the way into TMD or myofascial dysfunction, whatever. Remember, the patient came to you for a reason. One of the reasons they don't come to you, or rarely, is because I have periodontal disease, can you fix that? Very few people come into the general dental office with that as their complaint. So what happens when they are told they have periodontal disease and they need 4 quadrants of root planing for $900 or $1,200, and they were coming in for the $89 special, which was exam x-ray cleaning? How do you handle that? You have an obligation to tell them what's going on, but how do you do it without losing them? Because these patients don't know you, they don't trust you, and they are very prone to think it's going to be another bait and switch situation. So how do you avoid that? That's a problem. And I'll go back to about 10 years ago, maybe a little longer, when we had a patient-based practice, well, a marketing-based practice that in Florida that had a successful program that brought in minimally 120 new patients a month, and in some months over 150. And this was still the days of postcard marketing, but it really worked. The problem was, this is a practice that had been in business for over 30 years, and it was shrinking. Not only in monetary return, but in patient base. So we knew there was some serious issues, because that doesn't just happen. That means you're losing existing patients as well as not maintaining or converting your new patients you're bringing in through marketing. So we wanted to dig deeper and figure out what's going on. Well, we did what we'd call a retrospective study, meaning we went back and looked at what happened in the past and how is that affecting where we are today. So we went back a little over a year, like 14 months, and had them pull 120 new patients from 14 months before so we could see what happened to them. And we broke them into categories, basically 3 categories with some subcategories. The first category was, these are people, how many of these people came in and never came back? In other words, they had the exam and that's it. They didn't do any treatment. They were gone. They never saw them again. Second group did something. They came back. They might have had some periodontal treatment done. They might have had some restorative work done. They had something done, but they also have disappeared from the practice. The third group were people that are still with the practice, meaning they'd at least come back and were getting their teeth cleaned a couple of times a year and being managed in the general office. So after we broke it down, we wanted to look at what were the common factors. And we found it was periodontal disease. And interestingly enough, when you looked at the people who had the exam and didn't come back, the bulk of them did not come back because they were told they needed 4 quadrants of root planing, spend $1,000, so forth. So they imagine how they felt. They came in for the $89 exam x-ray cleaning and they said, oh no, you don't qualify, you need 4 quadrants of root planing. Well, what's that? And it costs $1,000. They're gone. The second group went ahead and had the 4 quadrants of root planing and scaling. The majority of these people, they had that done and they left and never came back. So they obviously were unhappy with what had happened. So we dug a little deeper. And the first group, obviously, were told something that they didn't expect and they didn't believe it. So they were gone. The second group went through the treatment, but they were so unhappy with the treatment, they didn't come back. As we dug deeper there, we found that in many cases, 4 quadrants of root planing were completed in a 90-minute appointment. You know, a cleaning is 60 minutes and 4 quadrants of root planing for 10 times as much takes 90 minutes, illogical. And then as I looked deeper, I think there were some problems with overdiagnosis and overtreating. However, the basic lesson is people don't expect to be told they have periodontal disease, and they don't expect to have to go through expensive treatment, and they just don't trust you and they don't stay.
Doctor, can I ask?
Sure.
What did you learn from this, and what did you come up with as a way to still get people the periodontal treatment they obviously need, but not lose them as patients to the practice, or at least not alienate them?
Yes. Well, it took a lot of thought and some development over time, as you know, and I've kind of retrospectively analyzed the approach we've taken. And I would call it reverting to something that's familiar to the patient, which would be the medical model. Periodontal disease is an infection. We all know that. It's a mixed infection. There's lots of bacteria, all different kinds, and we seem to develop and find new ones all the time. So what happens when you get an infection? You go to your physician. You know, if it's an infection and it's draining and it's got debris or needs to be cleaned up, they're going to clean it up, first of all. Then they're going to talk to you about the infection. They're going to put you on some medication, usually an antibiotic. They may put a bandage on, whatever. And then they're going to have you back after about a month to see how things are doing and see if anything else needs to be done. Of course, with the understanding if it flares up, come back sooner. That's the medical model. We all understand that. We've probably all experienced that to some level or another, but it's familiar to the patient. So we've switched to using that type of a model, so it isn't something that seems so foreign.
I got to thinking about the math you were talking about, where if we lose 100 patients in a month, whether they get a little of that treatment or not, we've lost probably 120 to 150,000 of dentistry over their next 20 years.
Yes, and in fact, I didn't give you the final number now that you brought that up. They were losing 90% of the patients that came in. So 90% of their new patients either came back once or never came back at all. And that was it. That's staggering.
Yeah.
But even then, they should have been growing a little bit, but they weren't. They were shrinking. And they had gone from one hygienist working 4 days a week and another hygienist working, well, two of them working 4 days a week. And they were now down to one hygienist doing 4 days a week, and the other one was down to doing 1 day a week. So they were losing their base that had been established in addition.
At least you had one hygienist to kill the survivors.
Pretty much, yeah. I mean, well, they were killing it in a bad way. So, and of course, there's some things that we can get into on that too about the hygienist, but with the patients, sticking with that and the medical model, the approach has to be different. It's not, this is calculus, this is bad, this is a pocket, this is bleeding, this is bad. We have to scrape all this stuff off of there and you'll be all better. That works with some people, but we found not a lot, as witnessed by this experiment or this review. And it is true, and many times you learn more from outliers than you do from people that are running within that narrow normal zone. And this was definitely an outlier case. So we learned a lot. So the change was the medical model. The hygienist still needs to gather the information either by 6-point probing if possible, or by a PSR, a periodontal screening and recording. Both are acceptable at an initial examination. At some point with a periodontal patient, you need to have 6-point probing, but it doesn't all have to be at that initial exam. So giving yourself a PSR score for each patient is adequate in the beginning. And it's probably all we really need, especially in people with type 2, type 3 periodontal disease, or even getting into type 4s. So the hygienist still gathers their information, points out what a pocket is, describes why we're probing it, and the consequences. But after that, the presentation changes. The presentation to the patient is, Mr. Peterson, you have an infection. That's what's causing all of this. That's what's helping create all of this debris, these hardened calcified deposits we see. This is a significant infection. If left as it is, it can cause you to lose your teeth, as well as have a number of other health issues related to the presence of this chronic infection. That sets the stage. The hygienist then says, I know you came in today for the new patient special, and that's great. I'm going to do as much as I can in the time allotted today to clean things up. And I'm going to polish your teeth because that always makes them look nice. I'm also going to have the doctor come in, and I'm going to talk to the doctor about putting you on an antibiotic for this infection. We'll then have you back in about 4 weeks to reevaluate everything, see how much improvement we've been able to gain, and to determine if any further treatment would be necessary and recommended. That's the medical model. So she tells them what she's going to do and why. She does a thorough debridement, meaning with a cavitron or an ultrasonic, knocking off as much of the debris as she can. And also don't be afraid to go below the tissue. Knock off everything you can do. And I realize you're only going to have about 20 minutes to do it. So you do what you can in that time frame, but always polish the teeth at the end. You're not doing full quadrant, full mouth root planing. That isn't what the ad said that the patient would get. You're giving them what you told them you were giving them, and you don't charge them anymore. They came in for this $89 special. That's what they pay, and that's it. Now, the whole idea of this is to start the healing process, and even more importantly, to get the patient to own the fact that they have a problem. Because they didn't think they had a problem when they came in, and you've told them they have a problem, you've shown them, you've started treating it like a medical problem. They have to now accept the fact that they have this problem. So you also give them a brochure, and there are a lot of good ones out there. And if they have any sense at all, they'll read through it. They'll get on the internet and look up periodontal disease and maybe watch some YouTube videos. That 30-day time frame between completing that debridement and reevaluating them is time for the tissues to respond and heal, and it's also time for them to wrap their mind around the fact that they have a problem. So,
how did this improve the outcome as far as to the practice, to patients staying, getting the work done?
well, you never get 100%, but we found that with doing it as poorly as you could, which was that office in Florida, you lose essentially every one of them. You know, when they had 90% of their patients, new patients that were lost, those were the periodontal patients. The ones that stuck with them didn't need anything other than a regular cleaning. So we found that we can get that up to 70 to 80% acceptance, which is huge. Now, there will be some people that won't come back, even though that you do not charge them for that return evaluation. This is your chance to spend 30 minutes or so, get the probings that you need, the full 6-point probing, and present the logical treatment plan. And the people that come back will have a different mindset. They'll understand it better.
And so this is how you can get the perio to the people without losing them right off the bat.
If you lose them from the exam, you never see them again.
Yeah, they're coming in from a marketing piece that lowers the bar, making it easy to get in, and then they feel like they landed in a bad place, the Halloween fun house, you know.
Yeah, I came here for a Yugo, and you're trying to sell me a Mercedes.
Right.
So, yeah. So you've got to get past that to the point that you have a problem, Mr. Patient. We're trying to help you with it. We're not trying to scam you.
Somebody's going to hear this and have a question where they can call in and we can talk about this.
Okay.
Thank you very much, Doctor.
My pleasure. Thank you.